Hi, I'm Amy McLenaghan from StableLab, and tonight we're here in Park City, Utah on the fringes of the AAEP Convention 2014. Tonight we have gathered 11 renowned equine veterinarians from all over the world because you, our customers, wanted real expert opinion, and here it is. This is unscripted, raw, real experiences expressed by those that have integrated serum amyloid A into their practice. This is the Innovator Circle.
So serum amyloid A is an acute phase protein, as we know, and it's supposed to help distinguish between potentially infectious and non-infectious diseases. And I'll just be curious what you all have found in your experience using this test for that.
I mean, I've looked at it in definitely cases that I've known that have had an infection, pneumonia. You'll see a clear rise. I've had a couple cases of an inflammatory bowel disease. I've actually had several of those this year. Then I've done serum amyloidase, and I've not seen a rise in those types of cases. So that's been, my experience with it.
We use it in our practice because doing just sports medicine and orthopedics, if I have a horse that gets off an airplane and has a filling in the leg, and I'm questioning, is this a traumatic cellulitis, or is this an infectious cellulitis, or do I have an early tendon that it's just too early to see? It's been very helpful for me as a tool in trying to separate out where do I put that case and what can I expect in the next 24, 48 hours.
So if you end up running on that case, serum amyloid A, and it's considered normal, less than 3, then what would you end up doing? Just continue to watch or do another test the next day? How would you handle that case that you think is traumatic in origin?
Well, if it's traumatic in origin, or I'm suspicious if it is a negative serum amyloid, certainly we're going to watch that horse the next day. Likely we're going to do a CBC at that time as well with a fibrinogen, but that's the really fabulous thing is I've got a serum amyloid A horse side right there. I don't have to wait until tomorrow to get the lab results back for a fibrinogen. Plus we know the serum amyloid A is much more sensitive and volatile in telling me an infectious process. So if I have a negative on it, I can assume I'm not going to start antibiotics. Same thing if I have a horse that comes off an airplane with a high fever and I'm concerned about a pleuritis or just a shipping stress. That serum amyloid A has been tremendously helpful in trying to differentiate, do I panic and put that horse on antibiotics, or can I sit on it and wait and watch it? And that's been really effective for me as a tool.
Had another case similar. These idiopathic tibiotarsal joint effusions that there's no history, they just show up one morning, they don't even have to breeze, and they're non-weight bearing, and you're scared to death. What happened? And nobody injected it, the horse didn't breeze, the horse didn't race. And I learned years ago that you had to be aggressive with those. You have to flush them first day before they get edematous and all that stuff. But then concurrently, we see these hock infections that are sub-Q or the tendon sheath, or they become like staph aureus. And they present similarly in the first day. And you got to make a decision pretty quick because the edema goes out of control. And so in those cases, I do the same thing. Synovial, because sometimes they're obvious, sometimes they're not. Synovial, peripheral. And I've had cases where the synovial was 0, the peripheral was 700 on day 1. That ended up being a MRSA case. Those, for some reason, I don't think it's distinctly MRSA, but it's resistant to penicillin and genicin. Luckily, it was sensitive to Baytril, but it was a staph aureus aureus, kind of a typical MRSA type bacteria. But we were able to leave the joint alone. So I think, and as far as your initial question of whether it's inflammatory or infectious, I was convinced early on that we're only detecting infection.
Now, Tim and Jan, you guys are some of the team vets for some top-level performance horses. What do you guys do? Do you guys use it prophylactically, as Philippe was talking about beforehand, get a baseline before you guys go shipping, or how do you all use it in your practice?
Well, I think one of the important tools for us is to know that horse getting off the transport, whether his fever is a mild shipping stress or something more important. And the sooner we can know that, the sooner we can start the appropriate therapy. So the more we can rely on a test like this to tell us at least that we don't have an infectious process, the more appropriate decisions we can make in the limited amount of time we have to deal with. That's probably the single most important use for me.
The first question, if a horse comes off a plane with a fever, first question from the coach is, can he be on the team in 3 days, yes or no? And if you can answer that quickly with that question, because if it is an infection, you're not sure. If it's not an infection, we're pretty sure that we can handle it. So that's number one indeed. I think the other thing is more in Europe than in the United States, as Philippe said, antibiotic and Richard, antibiotic use. In Europe, the use of antibiotics is by veterinarians is proclaimed to be the reason for MRSA to be so present in humans. So antibiotics are seen as the worst poison ever, unless you really have an infection. And so we do, also in the clinic, we don't use hardly any antibiotics anymore. For surgery, routine surgeries, we use no antibiotics. And if a horse gets up from the surgery room and has a slight fever, we measure SAA and then we decide should we use antibiotics or not. Even a horse before surgery, if they have slightly elevated white blood cell counts, we used to just put them under antibiotics for safety. We don't anymore. We do the SAA, and if SAA is negative, we don't use antibiotics. We put them on the table anyway.
Chris, you work on the Western discipline and the upper end horses there. How would you end up utilizing that test for your clients?
Most of the experience I've had is with respiratory cases. And it really dictates my worry factor to this point. Fibringens is a test that I don't really run anymore. It'd be a CBC and an SAA. A lot of those are referrals, that come in. So it dictates our worry factor. If we get one that's certainly above, it's the value that I don't really know how to interpret, but if they're above 100, I'll probably start 100, 200, I'll start some therapy. And most of these are viral infections that turn into bacterial infections that then turn into post all that lower respiratory disease, inflammatory disease. So I use it really as worry factor at first, start therapy, monitor therapy, and then decide when do I think it's safe to start some of those corticosteroids on those with residual cough and with that residual inflammation. We've used it. I've had one case that had a 7,000 SAA and it had a splenic abscess. So we knew that horse was afebrile, so it was chronic, or reasonably chronic, I thought, because he was afebrile. But we came back and drained that abscess and watched his SAA start to go down, and then monitored his therapy that way. Not only on ultrasound, but with antibiotics. With SAA, that's what dictated how long we stayed on antibiotics.
I think you raise a good point of some of these small airway inflammatory diseases. You do the ultrasound, they're clean. You do a BAL, you actually see, you got some inflammatory nidus going on there. And then the big question is, do you have an infectious component? You can do a transtrigger wash. Sometimes you get a contamination of the sample. You're still questioning it. You do the SAA, you see it's normal, then you feel comfortable doing the steroids. I think that's a big...
prednisolone at that point.
Yeah. And then, Jordan, your practice, you're pretty much the triage center down there for all these sport horses. How do you utilize it? What do you like it for?
So use it mainly for respiratory disease, shipping fevers, but anything that I would have normally run a CBC on, I'll run an SAA on as well. And I have seen some cases where I had a normal white count and an SAA of 30, and the horse actually ended up having strangles at one submandibular enlarged lymph node. And so I was I know 30 SAA is supposed to be a high value for SAA, but you're so used to looking at larger numbers when you see a positive that it's a little confusing sometimes.
That's the part I need y'all to tell me is when am I supposed to worry? When do I start therapy? When do I stop therapy? That's the part. And I really think that maybe the more we look in whatever disease entity we are using it for, it may be a little bit different in some of those things. You never really know.
We use it a lot, and I was able to look at a lot of these horses with serial SAAs. We always are hear about the 5-day antibiotics. Put them on for 5 days. And, I mean, there's nothing magical about 5 days. In human medicine, it's a lot longer. So when these sick horses came in, I would take serial SAAs, and we had, unfortunately in Saratoga, we had quite an outbreak. So we had probably 80 horses to look at, to follow. And what we found is that a large percentage of them, the SAA drops to a certain point. And some of those I kept going, some of those I stopped. Some of those came back up. But what I felt, the feeling I have after doing several hundred of these is that 200 is kind of a good number on the way down on the curve, on this side of the curve, where their immune system would take care of the rest.
And they febrile.
Yeah, yeah. A lot of these horses were afebrile quickly. They had one dose of nonsteroidals and that's it. And they were still, they still climb after about day 3, day 4. If I didn't see a plateauing, I don't need to see the number be lower than the previous day. But if I don't see a plateauing, if you were to graph it out by day 4, I would consider changing antibiotics.
You guys have hit on a couple things that are real important. Is historically, our profession hasn't had a good way to monitor duration of antimicrobial therapy. So much of what we look at is after the fact. And Jan brought up the issue of all the pressures we get. I mean, not only political pressures, but just the risks of performance horses with antimicrobial-induced diarrheas and that kind of thing. Is the least we can use, the better. And here I'm hearing some stories of people saying, you know, they're giving us a tool to be able to fine-tune our therapy.
You know, Nathan and I shared a case that was interesting in that realm. That was horse was on day 5 of Batril, I think, and the SA was still above 200. And I was going to go one more day, and he broke with diarrhea. Sent him to the hospital, recovered, but then he was done for the season. Went to Nathan, and he followed him out. I think he ended up on chloramphenicol, I believe. I'm not sure.
Yeah, he was on chloramphenicol for about a month. When he got shipped to me, he just wanted to get it clear, make sure everything's all right. Ultrasound his lungs. You know, you got some residual changes, you know, on these lungs. You know, some of these real bad pneumonias. So then I did serum amyloid A. It was less than 3. Put him to just let him get some rest and relaxation. Did well. Went out there a month later to get the okay to go down to Florida just recently. Ultrasound the chest. You know, saw some little more changes that I didn't see before. So I just did serum amyloid A. It was 75 at that time. I said, let's just give him another week off. Don't ship him right now. I went back, actually went back about 10 days later, ultrasound the lungs, and they didn't have as many comet tails, a few. So he must have been having a little something. SAA was less than 3. We decided to ship him out the next week, and ended up going to Lewis, and then from there, he was down there for roughly about a month or so. Spiked a fever just out of the blue. 102 and change, or did it go to 103?
It was 102 and change.
Yeah.
And, you know, previous antibiotic-induced colitis, and I just froze, basically, until I pulled the SAA. And the SAA was 75, I think. I think that's right.
Yeah, it was 75, and you and I were talking about when I said, dude, we're going to try to hold off antibiotics no matter what. You know, we had one of our friends, Meg Miller, take an ultrasound look. She saw some changes in the lung that I didn't see before, and we said, let's just watch. So then it went to 300, then to 400. But it was really weird because, as Luis and I were talking about, you're looking for that plateau. You know, how high is it rising? Well, it went to 75 to 300, but it wasn't having fevers. And we're like, okay, let's just wait, let's see what's going on. Then went to 300 to 420. You know, not as big as a rise from 75 to 300, so we thought, well, maybe we're going to be okay. And then all of a sudden, it topped up at 400. Like day 5, it went down to 75. Then we were like, okay. Then it's down to 3. Still the same changes in the lung, ultrasonographically. Some areas like a 5-centimeter region. And pretty much, you're just hand walking them and watching them.
So the only treatment was 10 cc's of bute on day 1 and management of the horse. Don't train them.
I mean, chloramphenicol in Europe, that's a deadly sin. You get put in jail for using that, for even possessing it. But the use of antibiotics, riders do report that if you have a horse on antibiotics, they notice they're not performing that well. So I think it's not only the political issue on it, it's also the performance issue on it. And if they're not performing that well, it means antibiotics, as life-saving as they may be, it does something to the system that's obviously not good for the system unless you have an infection. So I think it's only something we should encourage, to use antibiotics as restrictive as we can. And SAA is a great tool in that, I think.
I have a question for the group. According to your experience, when you have a horse that starts to have a little bit of a race of the SAA, this is my main question regarding the horses shipping back and forth to different shows. How much time do you expect them to have clinical signs of fever within, what, 12, 24, 36 hours? We know the SAA has a very short half-time. So what do you expect? I mean, I expect some answers there, because sometimes we freak out and see the race and say, okay, is it a problem? Or I'm talking even before StableLab, when we used to use the SAA on with a normal test, and you wait 24 hours to get the result. Now that we have StableLab, for sure we might use it even more, because it's so easy to use.
You're talking about screening horses that are still healthy?
Yeah, on a horse that arrives and seems to be so-so, you just pull up, get the CBC, the horse doesn't have all the clinical signs yet, and the SAA starts to race. So it's my question, maybe. I mean, I've seen you done a lot of series of...
I have, and it was interesting when I was looking at post-vaccination rises in SAA. We vaccinated a couple ponies on the racetrack, and it's a very limited research. I apologize to all the researchers around the table. But we were able to take, I took 3 or 4 ponies and we vaccinated them, and I took SAAs every 2 hours. And we found that the first detection of the, because I knew by that point that the vaccine will make it go up. The first time it showed up on every horse was 6 hours, but it was a really short, a little low number, like 6 or 7. By 12 hours, it was already in the hundreds. And by 24 hours, it was 300 or 400.
So if we have a race, let's say, of 200 on a horse that just got shipped but still does not have clinical sign, you expect this horse to be racing again, or?
He may, what I found is that they may not have clinical signs as high as 400 from what I've seen. Mm-hmm. I've seen horses race at with a 400 SAA and race poorly. Yeah, and well, that's where we are now. We've gone from what is SAA in my experience, what is it? How can we use it? Oh, it detects infection. Oh, we can see are we on the right antibiotics? Oh, are we on the antibiotics long enough? When can we stop treatment? To now, we're talking about evaluating pre-race on some of the bigger horses that take a lot of money. Owners fly in, everything's at stake. Maybe right before entry time, even if it's a grade 1, and most of them are. We're not there yet, convincing-wise. In fact, I have one trainer that's allowing me to take them in the near future, but he doesn't want to know what they are until after the race. That's great. I mean, I'm okay with that. And maybe we'll have to live through a lot of, well, he didn't run very well, and I can't find anything wrong. Well, he had a 260 SAA before he ran. You know, we'll have to have a lot of empirical evidence and anecdotal evidence to see where we are. But that's kind of after all this past year of seeing all these horses and following them on a daily basis, post-vaccination, joint infections, mostly respiratory problems. Now we're at the point where we might see them pre-race. I do believe that 200 and 300 and 400 SAAs, horses can get better on their own, a certain percentage of them. Then it becomes a management issue. What do you do with them? You don't put them right back to the racetrack. You walk them an extra day or an extra 3 days, and they allow you to pull serial SAAs on them.
Don't you feel a lot more comfortable if it's 200 on the back side of that than it is 200 on the first day that you found?
For me, what's more, if it's 30, I start getting worried.
I'm going to start worrying a lot more now. Because I haven't worried till 200. I'm going to worry at 30 now.
At 200, for me, when I'm on a horse has 5, 6, 7 days of treatment, and I'm at 200, I tell everybody to stop treatment because they can take care of themselves if you don't take them back. Now, I will need a 0 before I take that horse back to the racetrack. But at 200, I stop treating, and it may be one more day because that's a precipitous drop. That's what I've seen. I've seen that going from 2 to 300 to 0 can take a day.
And I use it as a post-operative monitoring tool fairly routinely, particularly in horses that we've fixed long bone fractures on, condylar fractures, spiraling condylar fractures that have massive implants in them. And you know, for the peace of mind with all of those implants, just monitoring, and particularly if they have a cast on, you know, so there's no way that you can visually monitor the incision or the area around it, and you're just feeling for heat under the cast or you know, lameness or any of those other signs of infection at the orthopedic site or on the operated leg. And I feel like it gives me the peace of mind that if there is an infection impending, that we'll catch it before we have that spike in temperature or before we can palpate the heat through the cast. And just out of interest's sake, multiple times on those same fractures, on simple condylar fractures, 2 screw fixations, I've run serial StableLab tests, and those have been 0. So for me, just the surgical trauma, surgical inflammation, I have not seen any rise in serum amyloid A. So if that also plays into your postoperative colic questions, I think your rises in SAA are probably not from incisional trauma or inflammation associated with the incision, because even on those long bone fractures, I've had SAAs of 0 routinely.
That's good. It's good to know. Yeah, there must be something more, because even when I talk to my colleagues in Europe that's been using serum amyloid A forever, they don't have yet to have a colic that doesn't have a marked increase. What I mean marked is, you know, 200 or more.
Sure.
So it's just kind of interesting. But yeah, the long bone fracture, the fracture repair, it's really good to know.
I just have one more thing to say. Earlier in our conversation, we were all talking about the time frames, you know, and as somebody, especially the respiratory things, you talked about sampling and that kind of thing, but here is something that we're describing and discussing that is right here and now. I mean, I love to, as a pathologist, look at, you know, cytologies and that kind of thing, but that's a time frame issue. And every one of you have talked about decision making now. And that's one of the things this offers. I mean, we may not know all the answers about it, but it seems like it's changing how almost everybody is making a decision. You described some time frames for your show horse and the race horses, and that's seemingly where we're going with this, is something that becomes a tool where we can make a more rapid decision than some of the typical traditional laboratory.